Now we move on to the next presentation by Dr. Nicholas Barrett. He's a consultant in critical care medicine at Guy's and St. Thomas NHS Foundation Trust, who trained in both anesthesia and intensive care medicine at Royal North Shore Hospital in Sydney, Australia. He is a clinical director for respiratory and critical care at Guy's and St. Thomas and has particular interest in severe cardiorespiratory failure, extracorporeal membrane oxygenation, and ECOR, including its provision in pregnancy. He is a specialist advisor to NICE and Healthcare Safety Investigation Branch. He is a past chair of EuroELSO, the organization supporting the development of ECMO in Europe, and provides advice to ECMO programs around the world. So, sir will be presenting on a very difficult topic, that's the strategy on difficult to wean from the VV ECMO. Sir is live now. Over to you, sir.
Thank you very much, Divya. Are you able to see my screen?
Yes, sir.
Wonderful. Thank you very much. Thank you very much for inviting me to this Congress. My sincere apologies that I couldn't join you in person due to particularly my clinical commitments at the moment. What I'm going to talk to you about over the next 15 to 20 minutes is how we can assess patients for the recovery from respiratory ECMO and how we can make that straightforward and systematic. I have no particular conflicts. So let's first of all look at the preconditions for weaning. So prior to being able to consider weaning, and this always sounds relatively straightforward, but never is. One is to deal with the underlying condition. The next is to follow and assess the improvement in the natural or the native pulmonary gas exchange, and then really getting the patient breathing with an acceptable work of breathing is also quite important. Now, investigation and management of the underlying condition has to start at the outset. So this is what we tend to do. So we undertake straight after cannulation for ECMO, we undertake a CT. Now we CT the chest clearly for understanding the underlying problem. We do a CTPA at the same time. We also do recruitment scans in order to think about how recruitable the patient is and think about the initial ventilatory strategy. We also scan the head and abdomen, looking for any additional problems. We do a broad-based immune panel. Now, the reason for this is that our patients come to us after being through a sort of pathway of medical treatment, and many of yours will be exactly the same. So they've often come through either the primary care or through the initial contact with the hospital, where their symptoms quite often are, well, I'm breathless with a cough and maybe some sputum. And so naturally, everyone thinks they've got an infection. They start on some antibiotics. They don't get better. They then go into a ventilator. They're upgraded on antibiotics. They don't get better. Some samples are sent off that may or may not be back by the time you start ECMO, and then you put them on ECMO. And what we've found is that roughly 1 in 8 patients have an autoimmune problem which was previously undiagnosed. And that can help guide therapies, particularly during the weaning phase when you're thinking about they seem very stuck, they've got a degree of fibrosis, and you might want to look at alternative therapies. Now, for these patients, waiting until they're in trouble and further down the track in our centre, these tests take a week to 10 days to come back. So we tend to send them on everyone at the start because it's so common. We send a broad infectious panel. Everyone gets an echo. I'm not a cardiologist. I'm an intensivist and an anaesthetist, and I only have one indication for an echo, and that is if the patient has a heart. There's no other indication in my mind, but I find that stood by me for many years as an important way to be able to pick up any additional problems, either with right or left-hearted or valvular issues relating to patients on ECMO. And then clearly we do a bronchoalveolar lavage, and we do cytology as well on that, looking at the balance. But these are the sorts of things that you can see. So you can see a classical ARDS here. where you'd be managing often the initial bacterial infection. You can see this sort of CT where these are the patients that once we get them onto ECMO, if we haven't been able to manage them in the prone position, for example, and early on, we may well consider putting them in the prone position after ECMO. Trauma is really important. We do some ECMO in trauma patients. They can do incredibly well so long as the great vessels are intact, and remarkably, this patient's great vessels were intact. And dealing clearly with, in this case, a post through the mediastinum is an important component of getting them off ECMO. Anchor-associated vasculitis with diffuse alveolar hemorrhage in our hands has done incredibly well on ECMO with quite a high survival rate. But we do need to think really carefully about the management of these patients. They need plasma exchange and heavy dose immunosuppression as well as gentle ventilation. And so knowing this from the start rather than finding it out days down the track is really helpful for the management of these patients. So we would start steroids and plasma exchange even on day one for these patients, with the secondary immunotherapy following a few days later once the plex is finished. This is an organizing pneumonia pattern. This is not COVID, though it looks a lot like COVID. This was in a patient with a rapid onset acute interstitial pneumonia, and again got better with immunosuppression. And don't forget PEs. There's a huge burden of PEs in this population. The other thing that we've moved to recently for the early diagnostics is metagenomics. So you do whole genome sequencing with a rapid PCR based approach on an entire BAL sample. It screens out the human, leaves you with the bacterial, and then you get everything that's in that sample. And that can be really important for patients who have unusual organisms. So we found this really very useful, particularly in those who are immunosuppressed. And this was an example of a patient who, at different points had different things. And so we found that in addition to the Candida albicans, which was only a small amount that they had in their grown sample, they had a large amount of Enterococcus. We then need to think about the native pulmonary gas exchange. So we treat the underlying condition, we get that better. We then look at native gas exchange, and we're looking at oxygenation, CO2 clearance, and imaging. The imaging is easiest. X-rays are great. They can help you follow the track the clearance of the native lung parenchyma. We also do sort of semi-regular CTs, particularly for our longer stay patients, looking at maybe every couple of weeks to assess progress, understanding whether they're going into a fibrotic phase ARDS or whether there's anything else. It can be really difficult to see in our patients' imaging whether, if you look at the one on the top left, is this patient got a bilateral whiteout because they've got big pleural effusions? Is it consolidation? Is it tracheal obstruction? Is it all of the above? Very hard to know. So cross-sectional imaging can be very helpful. The important thing when we're looking at the progress is the oxygenation over time. So in this patient, we've got down the bottom line, these will be in kilopascals, the systemic PaO2, and you can see that remains relatively static. We've then got in the yellow, the ECMO blood flow, and then in the gray, we've got what we call the 100% test, or the oxygen challenge test. So that's where you increase the oxygen on the ventilator. Our nurses do it every day to understand what the improvement in the level of oxygenation is, or the addition by the native lungs. And once you're getting to the realms of 30 to 40 kilopascals in this case, you're generally in a good place for the ability of the patient to oxygenate themselves. CO2 is similar, but slightly different. So CO2, here you've got in the gray line at the top, the systemic CO2. You see it doesn't change, again, kilopascals. You've got the blood flow coming down, the sweep flow rate coming down progressively in the blue over time as the patient's less dependent. And then you get an improvement in the end tidal CO2, and it gradually, over a week or two, will often approach the arterial CO2. Often doesn't quite reach it. There remains a degree of dead space. But this doesn't really tell the whole story about CO2. So we know that they're producing CO2, but CO2 production is based on both minute ventilation and the ability of the parenchyma and the vasculature to transfer CO2. So one of the approaches that we're using is to look at, obviously this at dead space, to look at this is just to remind everybody that the clearance of CO2 is non-linear from a membrane oxygenator. So you get an awful lot more going from 0 to 1 than from 9 to 10. But what we're doing a lot more of is volumetric capnography, where we're looking at the total amount of CO2 that's coming out, usually per minute. And that can be really helpful. So what you can do is you can measure the VCO2 coming out of the lungs, the CO2 production from the lungs, and you can measure the CO2 production from the membrane. And if you do that, then you get in a patient with a stable CO2, you're getting the total VCO2, and you're getting the proportion from the native lung and the proportion from the membrane lung. And you can then start to understand where the CO2 is being cleared, how much is being cleared by each side, and what happens if you change the membrane CO2 sweep flow rate. So as you come down on the sweep flow rate, if the VCO2 from the native lung stays exactly the same, you're going to struggle to get that patient off ECMO. But if the minute ventilation increases, if the VCO2 improves, and with the reduction in sweep, then you're likely to be in a better position to get that patient off ECMO in the near future. We also look really closely at work of breathing. So this is just one example. Most ventilators will have that now, which is the P.1 or the P occlusion, which is the pressure in the first 0.1 of a second of inspiration against a closed valve. And here you can see we're generating down to about -6 or so, -6, -7. Clearly, the greater that inspiratory draw at the beginning, the more effort the patient's having to put into their breath. We also need to look really carefully at the expiratory waveforms and make sure that the patient's adequately breathing out. This is a patient who had severe asthma, for example. So what are some of the barriers? Well, what we find is particularly things in the pleural space. As I said earlier, it can be very difficult in some of our patients to detect whether they've got a pneumothorax or not on plain imaging. They may have a loculated pneumothorax, they may have an empyema in there. I have two patients at the moment, both of whom had small air leaks in the mediastinum that led to significant surgical emphysema over the chest wall. So their chest x-rays are almost uninterpretable. And we can only tell whether they've got an underlying pneumothorax based on the cross-sectional imaging, which we're doing, every week or so. So that can be really, really very helpful. If the patient has a significant leak, and we do drain the leaks, if there is a significant bronchopleural fistula, we live with a significant bronchopleural fistula, we tend to get the patient awake, we get them spontaneously breathing, we get them tracheostomized or extubated, we get them off the ventilator, we leave them on ECMO. And if they've still got a big air leak that is stopping them from coming off ECMO, we use endobronchial valves. And we've got a growing amount of experience in placing these into our patients on ECMO and resolving the amount of bronchopleural fistula that's coming through. And that can assist patients in weaning from ECMO in this complex population. So I wouldn't fear a bronchopleural fistula. They're more awkward, and you do need access to endobronchial valves, but they can be managed in this population. The next thing to think about when weaning is very much the heart. Here, clearly, the right heart is very dilated. We had a patient with sort of progressive pulmonary problems there, pulmonary fibrosis. And so we start to worry, maybe this patient can't come off, but we need to manage the right heart. We need to look at how we can optimize pulmonary pressures and whether that patient can indeed separate from respiratory ECMO. We also need to fully understand the left heart and optimize, treat any heart failure that's present in terms of the weaning phase. And it's well known that in general weaning from ECMO that there is, or from ventilation in general, but also from ECMO, there is a real issue if you can't optimize the cardiac function overall, because you end up with a poorly optimized left ventricular function with a progressive rise in LVEDP, which maintains your pulmonary edema. So this is just one strategy looking at how we can manage these patients. So we think about them, we do an echo, and if you follow my rule, that's anyone with a heart. And then we think about how we can optimize the heart by managing their fluid status, managing with traditional medications for LV and RV dysfunction, whether it's systolic or diastolic. There are also patients who may need to go to the cath lab if they're with weaning starting to struggle and developing myocardial ischemia, even though they didn't present with a cardiac pathology at the beginning. This is a really interesting one. So if you look at the bottom of the screen, you had SATs of 85%. And you can see what we're doing here is turning down the blood flow. This is not quite as rare as you would think to see this particular phenomenon that you're about to see. So we're down to 500 mils of blood flow, or 400 mils of blood flow. We only do this transiently, and you can see the saturations here down the bottom in the 85 starting to rise. So this is a trap for clinicians. So in the patient who otherwise looks good, their worker breathing's low, they're spontaneously breathing, they're able to generate good volumes. Their saturations, when you come off and do a trial off ECMO, drop, and it's only when you drop the blood flows that the saturations start to rise, and it's because these patients have a patent foramen ovale and are gently jetting the deoxygenated blood from the ECMO through that. 1 in 5 of us or thereabouts have a patent foramen ovale, and an ECMO jet can certainly lift that up. And it just needs to be, you just need to decannulate the patient and move on and let the cardiologists deal with it if it remains open when the jet is gone. Other things that are really important, our patients are some of the sickest in the hospital, so de-resuscitation is crucial, and most of our patients are 15, 20, 30 litres fluid overloaded, so spending the time in a progressive negative fluid balance as soon as the patient's overall hemodynamics can allow is incredibly beneficial. I suspect more so in our population than other populations, and this sort of X-ray will clear with time and dehydration. The next is thinking about muscle weakness. Really important. We have to have a functioning diaphragm. We have to have functioning inspiratory muscles. And most of our patients, again, are the sickest in the hospital. And we really do need to understand what's going on with their musculature and optimize that musculature as best we can. Now, the reality is we can try to prevent it. We can try to do some things about it, but most of our patients, if they need prolonged paralysis, they need it. If they need steroids, they need it. We can keep them, if we have to keep them deeply sedated. So these are things we don't want to do, but often have to do, and they lead to neuromuscular problems. So the best solution is your physiotherapists. And so we are very dependent upon our physiotherapists and our nurses in mobilizing patients. We're very keen to start in-bed exercises very early in their stay, just passive movements to keep all the joints moving. But then as soon as we have the patient at a point where they are awake and able to cooperate, we start with them doing in-bed active exercises, then move them to side of bed, then chair, then standing. Sometimes we pop out to the riverbank just for a brief view And then obviously walking is incredibly important. This is very labor intensive. You've got multiple members of staff here. This patient's on a ventilator and an ECMO circuit. You've got someone standing behind for safety, but the only person who's not doing anything in this is me because I'm taking the video. So it's our nursing team and perfusions, etc. This is a patient who was not ventilated. And again, you can just see we're there, we're safely supporting her in her walk. We often use the sprinter cart from our ECMO machines to use almost as a Zimmer frame just to support the patients, support them back and front. You can also use alternatives, doesn't quite show as well. Oh, there we go. So things like in-bed bicycles, we do this with both arm and leg exercises, which is incredibly helpful. The last little bit, I realize we're probably over time. So the first things when we're thinking about is disease resolution has to be resolved. So you've got to find out what it is and treat it. We get them spontaneously breathing and broadly stable. We're not worried about renal impairment so long as we're controlled renal impairment on dialysis or their patient's spontaneous kidney function's adequate. We look for an oxygen challenge test greater than 30. And then what we do is we wean the blender, FiO2, steadily down. And we're looking for if there is a significant and rapid desaturation. We're also looking at the relative proportion of VCO2 from the native lung and VCO2 from the membrane lung. And we're looking at about an equal proportion, so 50%. And that's the point at which we start thinking about a weaning study. We do a lot of measurements. This is the series of measurements that we're doing. So we're looking at the transmembrane pressure, the resistances. We're looking at all these different measurements each day on the membrane lung and the native lung, the P.1 and the negative inspiratory force for the patient. And then this is what we do. So once we've decreased the FiO2, the FDO2, sorry, the membrane FiO2, if the saturations fall, we bail out. But then we bring down the sweep gas flow and we're looking for active measures of worker breathing. We've recently been doing more esophageal pressure in this population. So we'd be looking at more delta esophageal pressures to assess their drive. We're looking at their P.1s. We're looking at the VCO2 as a proportion of minute ventilation and to make sure that's reasonable. And we're looking that they're not particularly distressed. I was asked also to comment on transplantation. Now, I am not working in a transplant center, although it does happen within my broader trust. I don't work in that area. However, I do refer patients to transplant. I think it's really important to remember that transplant survival is about 50 to 60% at 5 years. So this is not the panacea. It's not the answer to everything. What do our team do? Well, if they're prior listed, so these are patients who are heading inexorably towards transplant and there's an acute deterioration, say they catch a pneumonia or something similar, then get the initial problem resolved and then get them transplanted as soon as possible, so that they don't lose any more muscle bulk. If they're previously well, we go through this process and we wait as long as we possibly can. So this is an example of what happened during COVID, where people were waiting really out to 4 to 6 months. Our patients who we've transplanted from de novo from ECMO, we're looking really at that sort of 6-month window prior to transplant. The reason for that is you get an awful lot of patients who just take a long time to get better. And I think we can all accept that if you're dealing with a patient in the long term and thinking about their longevity, you're far better off with your native lungs than you are with a transplant. So I would encourage you to wait. We haven't transplanted anyone before really a period of at least 6 months if they are previously well. So on that note, thank you very much.
Hey, Dr. Nick, thanks for the excellent talk. My name is Guru. I'm from the Mayo Clinic, Florida. I have two questions for you. Number one is how frequently you guys do your CT scan? And then number two question is regarding the duration of steroid. So you said that you all start kind of times 0, maybe if I heard correctly. So how long you do it and what's your dose strategy?
Yep. So the CT frequency, everyone gets a CT on admission without fail. And then it's on average about every 2 weeks. We don't see there's much point in doing it more frequently. So roughly every 2 weeks to see. And given that, and for us, the average ECMO run is around 2 weeks. So if you're not coming off at 2 weeks, it's time to look at a CT. Or the median, I should say, ECMO run. In terms of steroids are tricky. So we do look at different conditions. So if we have a clear autoimmune-based problem, say a diffuse alveolar hemorrhage, for example, then we use the fairly standard approach. So we'll have, a pulse of methylprednisolone, depending on the patient, 500 to a gram for 3 days, and then look at a mg per kg BD for sort of a week or so, and then cut back from there. So we use the rheumatological dosing schedules for those sorts of conditions. We do use the rheumatological rather than the renal. We find that the renal dosing schedules are a little bit lighter than the rheumatological ones. So we do go a little bit heavier. We've found that with a few of the patients, they do break through, or they don't sort of last with the renal doses. And we also delay going on to orals, even if the patient appears to be absorbing. We've had a few patients who've gone backwards after we've converted to oral, even though they, for all intents and purposes, they appear to be absorbing their food and drugs. We don't have a good explanation for that. In the ARDS population, we tend to use the Dexter ARDS dosing, so 5 days of 20, then 5, and then wean. So that's what we would tend to do. I think one of the things that we really need to look at, and I think one of the great things about the COVID experience was we stopped dealing with ARDS and we started dealing with the disease. And I think the next phase of studies along the lines of the REMAP CAP series has to be, let's do steroids in flu, steroids in adenovirus, steroids. Let's stop pretending it's all the same and really understand, because these treatments, they're not benign.
Agreed. So thank you for that. Again, I do agree as well as disagree with your proposition regarding the transplant, So it's a more kind of, debatable situation for sure. Whom should you and how you should forget? As you know that including our center and more US people are pro-transplant with respect to the ARDS, as well as defining whether it is reversible or irreversible. So maybe some other time. So I'll pick your brain and see what you guys are doing. I did talk to the Caroline from Leicester recently regarding their plan. So they did have, long run. I was surprised, like they as you mentioned that you guys wait for 6 months or so. That's not going to happen here. We just transplanted a lady with HIV and PCP pneumonia, which was diagnosed in October. She got the lung yesterday before I flew to India. So it's a different perspective, but thank you for that. So bye.
My pleasure.